I want to add my welcome to everyone. Thank you so much for joining us on this Saturday morning. I am Tian Zhang. I'm an associate professor of medicine at UT Southwestern and the Harold C. Simmons Comprehensive Cancer Center in Dallas. I'm happy to be invited, and thank you so much for the KCA to invite me to discuss an overview of kidney cancer this morning. We have about 45 minutes, and hopefully I'll share lots of slides, and also if there are questions, I'm happy to take them in between or at the end. With that, my disclosures, the ones in blue, pertain to companies that have approved therapeutics in kidney cancer. All right, so today I wanted to talk through disease settings and pathology, some of our newest systemic treatments with immunotherapies, and in particular toxicities, and think about side effects as you all start facing some of these treatments. The newest addition in the adjuvant landscape, so post-op treatments, and then treatment selection if time permits. So you're facing the new diagnosis of kidney cancer, and most often we're wondering what the pathology is like and what exactly is in the kidney cancer. So of all the kidney cancers that are diagnosed worldwide, the majority is clear cell kidney cancer, comprising 70 to 80%. There's of the non-clear cell bucket, there's actually a variety of pathologies, of which papillary is the most common, around 15%. Chromophobe, oncocytoma, we think of as more benign, as these do not spread to other sites. And then collecting duct, translocation type, you'll also hear about medullary type. These are all very rare histologies of kidney cancer. So what do these look like? They look very different under the microscope. With the most majority of clear cells, they have very, very large cells, clear cytoplasm, make a lot of protein. And so that's why they're called clear cells. Papillary have these papilla fronds, if you will, and there's both type 1 and type 2 etiologies. And then chromophobe looks very different as well under the microscope, and oncocytoma are these very pink foamy cells, if you will. And they're all associated with different mutations. I won't get into those or belabor those, but certainly we have come a long way in terms of understanding genetic alterations that lead to each of these tumor types. Of note, and you'll hear me talk a little bit toward the end of this talk, there is a sarcomatoid differentiation that can present within each of these histologies. And these are where the tumor cells become a little bit less differentiated. They look almost very spindle-like, and they look almost like sarcoma, which is why it's called sarcomatoid. And sarcoma is more of a feature of more muscle-like cells. So that's why these cells are a bit different than what we see in each of these histologies, but they can occur, and you can see that as part of the pathology report if you're looking through any sort of surgery or biopsy reports. All right, so what about disease settings of kidney cancer? Often we're looking at stage of the kidney cancer with early disease where cancer is localized to the kidney. 7 centimeters is generally our cutoff between what we call T1 and T2, or stage 1 and stage 2. Sometimes these are locally advanced, but still resectable and still operable, meaning the surgeon can go in and remove the tumor with the kidney. And in many cases, they're locally advanced with involving the perinephric fat, or they've kind of grown into the renal vein and up into the inferior vena cava, as demonstrated here in stage 3 picture. And then what about stage 4? So this is something that we often are seeing a lot of in kidney cancer, unfortunately. And most medical oncologists will treat stage 4 kidney cancer in the metastatic setting, where it's spread to lymph nodes or other sites. And some patients can have surgery first to control symptoms if needed in the local areas. We call some of these before surgery as neoadjuvant, before getting into surgery. And then just for terminology's sake, after surgery or post-op, we define this setting as adjuvant settings. And so what you'll hear in the third portion of this talk is we are having more and more advances in improving our adjuvant outcomes as well. So where do we all start? Well, we started with understanding a syndrome of diseases called the von Hippel-Lindau syndrome. And this is how we started understanding clear cell kidney cancer. There was a German pathologist named von Hippel and a Swedish, a German ophthalmologist named von Hippel and a Swedish pathologist named Lindau. And together they made these observations that there were vascular changes in the eye, in particular in the retina, as well as in the pancreas, in the ear, in the adrenal glands, and also in the genital tract of patients, and then of kidneys. And they described the syndrome that we now call von Hippel-Lindau syndrome, and has many vascular malformations like behind the eye and the retina, hemangioblastomas involving the brainstem or cerebellum, pheochromocytomas occurring in the adrenal glands, pancreatic cysts, and then also papillary cystadenomas. But the most malignant portion of this syndrome is clear cell kidney cancer. And that's how we started to understand the associations of kidney cancer with the alterations in blood vessel formation. And so how far have we come? We've come a long way to understanding angiogenesis, which is the process of blood vessel formation, and the molecular changes in the cells as we get into aggressive kidney cancer. And so many of you are familiar with the work that earned the 2019 Nobel Prize in Physiology or Medicine, looking at molecular biology of oxygen sensing and what happens when the von Hippel-Lindau protein is lost, and when the cell cannot sense and inappropriately builds up the HIF complex, the hypoxia-inducible factor complex, and makes it downstream regulators to increase blood vessel formation. And then my own colleague here at UT Southwestern, Jim Bergolis, also defined a more aggressive type of kidney cancer that has alterations and mutations in the BAP1 gene. So all of these molecular features have really impacted our understanding and what we can do to therapeutically target these pathways in kidney cancer. So there are now many treatments targeting angiogenesis, blocking blood vessel formation, and we have a variety of mechanisms. There are many drugs that are either small molecules and they inhibit the receptor that allows blood vessels to form, or they are monoclonal antibodies, we call, also blocking the extracellular portion of these receptors. And then we even now have small molecule inhibitors to block the HIF complex. So many of you may have heard about the belzutifan story, and I'll talk about some of the trials that are ongoing to build belzutifan into our trials. There was also very early on a subset of kidney cancers that we knew to be highly immunoresponsive, meaning they responded to activation of the immune system. And for a long time, we treated patients with high-dose interleukin-2. And this treatment had extremely toxic side effects. Patients had full body rashes, low blood pressure. It caused kidney and liver failure, basically, in a very controlled environment. microenvironment. And when we got them to the brink of causing almost kidney failure or liver failure, we stopped the treatments and brought them back. But it activated systemically patients' immune system. So in a very non-specific way, activated their immune system. And we did all this with the very toxic side effects because there was this 11% or so complete response rate and very long survival intervals. So if you look at this particular Kaplan-Meier curve, we're following patients all the way out to 10 years. And there's about 10-15% of patients who are still alive 10 years out, even with metastatic stage 4 disease at diagnosis. So that was the history of why we think kidney cancer is immune responsive and why we target the immune system in this setting. So with that, setting the background of why we do what we do, I want to talk to you a little bit about how far we've come in terms of our systemic treatments and some of their toxicities. So in the past 8 years or so, there have been a number of first-line metastatic kidney cancer trials that have gained registrations and approvals for immunotherapy combinations. And so many of these trials enrolled patients who had metastatic clear cell kidney cancer, no prior treatments, and a good performance status. These patients were all randomized to either sunitinib, which was our common standard for treating patients in this metastatic setting, blocking blood vessel formation, versus a host of immune treatment combinations. And so you will hear people throw terms of Checkmate 214, which is ipilimumab and nivolumab, this trial enrolled more than 1,000 patients, and you'll see some of the results here. Javelin Renal 101 was a trial with axitinib with avelumab. Keynote 426 was a trial with axitinib with pembrolizumab. Many of you may be on this combination. Emotion 151, bevacizumab and atezolizumab. Now, this trial did not reach registration. It did not meet the primary endpoints. But there are very interesting molecular features that we'll talk about. Checkmate 9ER, which was cabozantinib with nivolumab, and Clear, which was lenvatinib and pembrolizumab. So we'll take you through a couple of these trial data and show you why these immunotherapy combinations were ultimately approved. These patients were all treated until disease progression or unacceptable toxicities, and their primary endpoints revolved around overall survival and progression-free survival. And you'll hear us throw these terms around, but it's overall survival, hoping to make patients live longer, and progression-free survival, delaying time until disease progression. And so what did we see across these trials? Well, we saw that all of these immunotherapy combinations improved overall survival. It got patients to live longer. And these Kaplan-Meier curves, if you're not used to looking at them, are basically one curve of patients who were treated with the immunotherapy combination. The other curve, all of these trials were benched upon sunitinib as a control cohort. So all of these patients had demonstrated improvements in overall survival compared to patients treated with sunitinib. And so these immunotherapy combinations are making patients live longer, and hopefully we're also maintaining some quality of life during that time. They also tend to have more improvements in patients who we term as IMDC intermediate or poor risk. And this is a set of criteria where we're looking at clinical features of inflammation, but in particular, those patients who do have intermediate or poor risk disease, they tend to do better with immunotherapy-based combinations. There's a whole controversy in the field about how do we treat favorable risk disease optimally. You'll see that in some of these very long-term follow-up of the Checkmate 214 trial, these curves, if you will, are starting to overlap and cross over. And so there's some thought that even in favorable risk disease, perhaps there's some signal to using immunotherapy combinations. But that is a very controversial topic. But certainly for patients with intermediate or poor risk disease, I think we as a field are pretty convinced now that patients should be treated with an immunotherapy combination. How about progression-free survival? How are we getting patients more time free from disease progression? And the answer is yes. Across all of these immune-based combinations, we're getting patients more time on the same treatment. And in particular, if you look at Checkmate 214 here in the top left, there are 30% of patients at 5 years that are not experiencing disease progression. And that, I think, is a really important point to look at this plateau, if you will, at the far end of the curve, because that shows you a portion of patients who are still on their first line treatment, or if they've stopped, they're not going on another treatment. And so this is a really important endpoint that I think when we're looking at medians, you see the median of these curves are not very different, but that tail is quite different. And we're still needing more follow-up for the immunotherapy-based treatments that are also adding in the anti-angiogenic agent across the Keynote, Checkmate 9ER, and CLEAR studies to really see if there's the same type of curve plateau that we see in Checkmate 214. How about safety? So safety on these treatments is all tabulated in these trials when we present them. But what does it mean for patients? Well, when we talk about immunotherapy-based combinations in the clinic, I always talk about activating the immune system where the immune system is most active. So on the skin, it causes a rash. In the GI tract, it can cause diarrhea or colitis. Very rarely will it cause inflammation of the liver or the lungs, what you see here as hepatitis or pneumonitis. And then there can be certainly effects on the endocrine system. So that includes the pituitary, the thyroid, the adrenal glands, and the pancreas. And so you'll see of these, the thyroid is the most commonly affected. And so we're watching all of these toxicities as patients are on treatment, as they come back for labs, as we consider another cycle of these intravenous treatments. Now, what happens when we throw in the anti-angiogenic agent or the blood vessel blocker? So you'll see these other trials all have the addition to immunotherapy of one of the small molecule inhibitors that we talked about initially. So axitinib, cabozantinib, or lenvatinib, all are agents that block blood vessel formation and then have some extraneous effects. And so when that happens, we have some toxicities that are more likely to be ascribed to the anti-angiogenic agent. These include things like high blood pressure, what we see as PPE here, or palmar plantar erythrodysesthesia, and this is also known as hand-foot syndrome, where there's a rash on the palms of the hands and the soles of the feet, can be blistering and painful. And then also things like mucosal inflammation, stomatitis, mouth ulcers, these tend to be more ascribed to the small molecule inhibitors. But there are also overlapping toxicities, like the diarrhea can be caused from either one. Increases in liver function testing, the ALT, AST that you see here, these can also be overlapping and either due to these the oral treatments or from the IV treatments. And so when we're thinking about these, it's very important to find them early. So especially the diarrhea, if you're starting to have diarrhea on these treatments, important to bring them to mind early so that we can start to manage them. So here I'm showing you the Venn diagram of side effects with immunotherapy in the blue circle, with the anti-angiogenic agents on the red circle, and areas in between where we overlap. The one thing I forgot to say in the last slide was the hypothyroidism. And then very rarely it can alter mental status in the form of either swelling in the brain or encephalitis or PRESS syndrome from the anti-angiogenic agents can occur, but these are exceedingly rare, and hopefully we're recognizing them early. So how do we manage these side effects? I think it's really important to catch side effects early and for you to have a direct line to your treating oncologist when you're on these treatments. We often will hold the anti-angiogenic agent first. The related side effects should resolve faster when we're holding these small molecule inhibitors. The immune toxicities take a little longer to resolve, and often we'll start with steroid treatments and then also build on them with other treatment options. And then finally, we're considering drug-drug interactions for any of the small molecule inhibitors, particularly with statins that are also cleared through the liver. So important to look at what other medications you're on as we're getting you started with some of these treatments. What trials are we doing now? So I've shown you in the last 8 years or so, phase 3 trials that were benchmarked on sunitinib. And now that we've come this long way, now our control really needs to be immunotherapy-based combinations. And indeed, we have multiple phase 3 trials that are ongoing across the country and across the world now that are really building upon what we know about the benefits of immunotherapies. And so there are 4 trials that I'm highlighting here. And I'll show you the 3 ongoing here shortly. Of these 4, the only completed one is Cosmic 313, which is building on a triplet of ipilimumab, nivolumab, and cabozantinib. The 3 that are ongoing, Pedigree, I'll show you in the next slide, is an adaptive phase 3 trial that's run in the US. LITESPARK 012 is a triplet trial, really building on lenvatinib and pembrolizumab. And then PROBE is a trial that's being run in the cooperative groups in the US that's looking at the question of when to do surgery to the primary in the face of metastatic disease. So this is a very busy schema of Pedigree. Many you may have heard of this trial that we're running in the Alliance Cooperative Group. This is an adaptive trial that's built on starting ipilimumab and nivolumab for intermediate or poor risk disease. And then as patients get their 3-month assessments, adapting treatment to their responses and building on the randomization between nivolumab versus nivolumab with cabozantinib. And so the study activated about 3 years ago at this point, and we are enrolling very well. And if you're on Pedigree somewhere out there, we do appreciate everyone's participation in the trial. LITESPARK 012 is a triplet trial. You'll hear a lot of us throw around doublets versus triplets. Well, triplets are here also for kidney cancer. And this is building on lenvatinib with pembrolizumab with either a triplet of belzutifan in addition to lenvatinib and pembrolizumab, or quemliclustat, which is a anti-CTLA-4 agent, very similar to ipilimumab, adding to lenvatinib and pembrolizumab. So this trial is also ongoing. We also have this one open, and it is a very exciting trial, I think, to build on triplets. And then finally, the PROBE trial is ongoing. This is a trial that is being run from the SWOG cooperative group. Everyone is started on immunotherapy-based combinations. and they're randomized after 3 months to either continuing the immunotherapy-based combination or nephrectomy, so surgery to the primary site. And so hopefully we're also getting there to seeing what the effect and how to do surgery to the primary in the setting of metastatic disease. So a quick summary of first-line metastatic clear cell kidney cancer. We are seeing overall survival benefits. Our patients are living longer with these immunotherapy-based combinations. Currently, there are no head-to-head trials of the anti-angiogenic agents with immunotherapy combinations versus the pure immunotherapy combination of ipilimumab and nivolumab. We do see better outcomes of the immunotherapy-based combinations with anti-angiogenic agents when we're comparing against even sunitinib alone in favorable risk disease. And I think it really depends on the patient and the clinical features that they bring in, any prior nephrectomies, any and the bone or symptomatic or burden of disease burden, and the patient's goals of treatment are so important when we're deciding on the first line of treatment for these patients. And I just want to show you a patient of mine that I treated. I was in North Carolina for a number of years, and this patient I started treating back in 2017 when we initially saw the results of Checkmate 214. And at the time, he presented at age 47 with just innumerable symptomatic liver and lung metastases. When I met him, he had significant pain from the liver metastases. He was anemic. He had very high platelet counts, and he was less than a year from his initial surgery to the primary. His lungs were also filled with metastatic disease. And so we really took a leap of faith and started him on immunotherapy treatments with ipilimumab and nivolumab for a little more than a year. Even after the first 6 to 8 weeks, he had less pain. He felt better overall. And as we got into 3 months in, all of these tumors in his liver and his lungs were improving. And you see when we held in November 2018, he developed a sports-related injury. And so we held treatment. He had very clean scans to the point where we really couldn't see any of the spots in his liver. So he took a 15-month treatment break. During that time, we continued all the scans to surveil and see, and if we would catch anything early. In February of 2020, he did develop a new spot on the liver. And so we re-challenged with nivolumab on its own. And he had stability for another year and a half. And unfortunately, in speaking of side effects and toxicities, these really can occur at any point along a treatment journey. And so in August last year, he developed immune-mediated diabetes that was insulin dependent. And so we held again, his treatment break is currently ongoing. And over the last 5 years, he is now 52. He has triplets in high school, and his youngest is in middle school. And he's reaching all those milestones and seeing parts of his life that we really didn't imagine possible when he first presented to us. And with that, we'll come to the third part of the talk and see if I think what we'll do actually, Sally just shared with me that we have about 10 minutes, that I'll talk through the adjuvant landscape, and then we may skip the treatment selection, and I'll take questions after this adjuvant portion. So what happens now when we have such great immunotherapy combinations in the advanced settings well, we like to bring them earlier in the disease courses. And so in this particular case, we like to bring them in the post-op or after surgery settings of the adjuvant setting. So there's certainly been systems and factors that have been associated with disease recurrence and survival. You'll see here tumor size, tumor necrosis, symptomatic disease, any positive margins at the time of surgery, and patient's performance status all can affect what we see of and their prognosis of time to disease recurrence as well as survival. And then when we're thinking about this adjuvant setting, we're often thinking about risk and benefit. So benefit of preventing disease recurrence and hopefully prolonging overall survival versus causing some side effects, right? So changing quality of life, causing side effects, some cost implications, and then in the setting of our IV treatments, inconvenience of coming into the cancer centers for the patient's treatments. And so as we have now had improvements in the treatment landscape of all of the FDA-approved therapies that we have, we're now also adding to the adjuvant landscape, which you see in the red. So in 2017, sunitinib was approved, and just about 6 months ago, in November of 2021, pembrolizumab was approved. I'll take you through a little bit of that decision and trials. So as our systemic treatments are improving for metastatic disease, we're also pushing them into the adjuvant setting to prevent disease recurrence. And we've gone through the cytokine eras of interferon and interleukin-2, the small molecule TKI era of targeting anti-angiogenesis, and now we're firmly, I think, in the immunotherapy era. And so how did these translate into adjuvant benefits? Well, in the cytokine era, there was no benefit in the adjuvant setting, too toxic to warrant treatment in the post-op setting. In the VEGF era, there were some mixed results. I'll take you through a little bit of that. And now in the immunotherapy era, the Keynote 564 was the first reported trial that showed a definitive benefit of pembrolizumab compared with placebo. So early on, there were some mixed results of looking at small molecule inhibitors to block blood vessel formation. This was a trial called ASSURE, treatments with sunitinib versus sorafenib versus placebo. There was no difference in disease-free survival outcomes or delay of treatment recurrence. But there was a trial called STRAC, sunitinib versus placebo, which improved the disease-free survival interval, but not overall survival. So it delayed time until disease recurrence, but didn't necessarily get patients to live longer when they were treated with a year of sunitinib versus placebo. And so in this setting, we kind of thought about, is this treatment of choice in particular important, and how is this disease-free survival outcome truly indicative of our treatment? Well, the randomized trial, we published a review and a discussion about this in the past year with Pavlos Masal. But in terms of disease recurrence, this is a pretty important endpoint in the overall scheme of things. If we're delaying time until disease is recurring, then hopefully we're also delaying a time until death or the overall survival outcome. But that disease recurrence is an early and more direct effect of what we're seeing of the actual treatment. And so, and indeed, when we're thinking about sunitinib in the adjuvant setting, we did obtain an approval for sunitinib in this setting. But there wasn't a lot of uptake of using sunitinib because the field said, well, the benefit may be that we're preventing disease recurrence, but man, we're causing a lot of toxicities of high blood pressure, hand-foot syndrome, the diarrhea, the mouth ulcers. Not worth it for a year of treatment. It was inconvenient and it was costly. But when we recommended it, it was likely more given for younger patients who had a lot of anxiety about disease recurrence and who had a very high threshold for tolerating these toxicities. So along came the Keynote 564 adjuvant pembrolizumab trial. This was all patients with high risk disease treated with pembrolizumab versus placebo. And patient baseline characteristics you'll see here of patients randomized to either pembrolizumab or placebo. Most of these patients had intermediate or high risk disease, and some patients had at least one site of metastasis that was resected before they were treated. So as we looked, the disease-free survival outcome was certainly improved with 1 year of pembrolizumab treatments. You'll see here both at 1 year as well as 2 years, patients are doing better in terms of preventing disease recurrence compared to patients who were treated with placebo. And in particular, there was a small population of patients who had this metastatic disease that was resected and otherwise free of disease that seemed to do better. This may be a function of how we defined it in that particular trial, but certainly a signal there that these patients are at high risk for disease recurrence. The overall survival benefit was not quite as dramatic, and I would say this is certainly not statistically significant and something that we need to further follow up to see if that disease-free recurrence endpoint can be a surrogate for overall survival in this disease setting, particularly as patients hopefully have access to immunotherapy-based combinations if they do recur and have disease progression. How about the adverse event profile? Very similar to what we described for immunotherapy toxicities, and in particular pembrolizumab alone. We have used for many patients now across solid tumors. And so very similar, nothing unexpected from this trial of rashes, diarrhea, endocrine toxicities, and fatigue. These in particular were the immune-mediated adverse events, and again, very much expected for pembrolizumab. And as a field and in medicine in general, I think we're getting better and better at managing all of these immune-mediated side effects. Quality of life too was presented about 6 months ago, and there was no difference in patients who were treated between pembrolizumab and placebo during this time. And the comment here, I do think severe immune-mediated adverse events may not be captured as well on this more global look at patient cohorts. So certainly still a patient-driven decision. So pembrolizumab was approved in the adjuvant setting about 6 months ago in November 2021. I think it's still a discussion about how we're certainly preventing disease recurrence. There's a question and more data is needed before we can say that it'll extend overall survival or help patients live longer. There's grade 3 or higher toxicities is quite low, but severe toxicities can be quite severe, can be life-threatening. There's a cost to our patients and our payers, and there's the inconvenience of IV treatments every 3 or 6 weeks while on treatment of 1 year pembrolizumab. So certainly some discussions and patient preferences and priorities, tolerance for toxicities, and their goals for treatment. And it's a really much a shared decision-making for whether this makes sense when we're deciding to embark on a year of pembrolizumab treatments with our patients. There are several ongoing adjuvant trials in kidney cancer, some of which have completed accrual. The Emotion and Prosper trials, the Checkmate 914 and Rampart trials, I believe, are still ongoing. And so finally, some takeaways for adjuvant therapy. As our systemic treatments are starting to improve, or hopefully also improving outcomes in this adjuvant setting, the disease-free survival endpoint is a good endpoint, reflects direct treatment effects of that randomized treatment in this adjuvant setting. And so pembrolizumab did show disease-free survival benefit and a trend toward overall survival benefit. We're weighing treatment benefits versus toxicity for every patient. And there's several ongoing trials with adjuvant immunotherapies. And so with that, I think we will flip to the end. And I do want to thank everyone for your attention and happy to take any questions. So I see a question in the chat. When will sunitinib be replaced as the reference drug in clinical trials? This is a great question. Hopefully I answered it in the course of the talk. There are very few ongoing trials now that are referenced against sunitinib. And the ongoing first-line trials are all now benchmarked against immunotherapy-based combinations. So the 3 ongoing trials that I showed you, so Pedigree, LITESPARK 012, and also Probe and Cosmic 313 are all benchmarked against immunotherapy-based combinations, not against sunitinib. Another question from Sally. When will survival rates be updated to reflect all the new information? I think this is perhaps asking about the Keynote 564 trial. If it's not, please feel free to correct me. Survival endpoints are really benchmarked against and reported when we have the actual events occur. And so for overall survival, the longer we're waiting, the better patients are actually doing on the trial. And so we usually report after a certain number of events have occurred, and we do think about updating these survival outcomes as the events are occurring. And so many of you may be aware that at least for 564, there was an update made at GU ASCO this year in February of 2022. Which continue to show specific patient populations, high risk, that benefited from a year of pembrolizumab and had some more overall survival events. But again, not enough to show a statistically significant improvement yet in that benefit. I see another question in the chat. I'm now over 17 years past my own high-dose IL-2 treatment, have had no recurrence and no further treatment in that time. When or how can we use new knowledge to find patients more likely to respond to high-dose IL-2? To that, I say congratulations. That's wonderful that you had such a wonderful response to high-dose interleukin-2. It's hard in the setting of really targeted immunotherapies that may not cause as much toxicity as interleukin-2 to try to select patients for high-dose IL-2. But there are certainly centers around the country, my own here at UT Southwestern, that still offer high-dose IL-2. And I think in the right settings, perhaps the treating oncologist may recommend high-dose IL-2. It is still one of the possibilities of treatment in the metastatic setting. But I think most centers and most oncologists are more likely turning toward these targeted ways to activate the immune system in hopefully less toxic ways. Another question here, what about treating small clear cell carcinoma treated with drugs before surgery? So I think the perioperative question is a really good question. So how can we debulk, shrink disease and allow for easier surgery perhaps? Or how do we go about using our drugs before patients go to surgery? And there's been a series of trials that are all sort of small phase 2 trials done in the perioperative setting. There's a couple that are ongoing that show that we don't change very much the time until surgery. We also don't change the actual surgery approach with treatment, systemic treatment with drugs before surgery. And so I hope that shows that it is safe to use in the right settings. We certainly work in a multidisciplinary way with our surgeons to decide which patients need to go onto systemic therapy first for some early disease control before they get tailored to have their surgery. And hopefully these patients generally are patients who have a bit more systemic effects of their cancer, so more inflammatory cancers, or patients who have high calcium levels from their disease. And so we have to go about controlling a lot of the systemic effects before we can get them to a safe surgery. Great questions. All right, I think we're getting to the end of our question and answer time. I know there's a whole host of wonderful talks ahead for you all. And thank you everyone for having me join the KCA Virtual Patient Symposium today.